So I'm gonna get started, and hopefully those that are grabbing some more caffeine to make it through the rest of the day, they're wise to do so. So what I just to kind of recap where we just went through. What we tried to describe for you was some of our initial results, and I think for those of you, actually, show of hands, how many were here at the OMOP Symposium last year? How many people were really scared of the OMOP results last year? It looks like pretty much the same hands. So we think, as Mark showed in the analogy of climbing the mountain, we think, last time we thought we were making performance improvements, but we also felt like we were running into some questions we couldn't answer. And that really was what gave us the genesis for focusing on why we were observing what we were before and what we could do about it to make it better. And so what we just talked about was really some of the, just explicit suggestions that we had come up with in an evaluation of the performance of those suggestions that, at least from our perspective, felt like we were starting to take steps in the right direction up that mountain. Still a long way to go. But hopefully feeling a little bit more positive than maybe where at least we were a year and a half ago. Show of hands, how many people are feeling a little bit better about where we are than we were a year and a half ago? All right, and we got two clappers, so that's good. All right, so I'm going to shift gears a little bit. So what we just talked about was basically, I just wanted to kind of lay it on you, what are those recommendations and what we observe to be performance. As you can imagine, there's an awful lot of data that went into that and some additional insights that came from those results. And what I want to do is walk you through some of those other insights that came through as a consequence of the experiment results that we just shared with you. And so for those of you who are still playing with Elmo, you can just keep doing that, but there's going to be another chance to play with Elmo in just a little bit, so you can bear with me a little bit. All right. So I provided 4 practical strategies for how you can think about using a risk identification system. What we're now going to do is walk through 5 different observations that we observed through our experiment. Principally, we're going to talk about performance of different methods. Actually, a couple folks grabbed me on the break and said, well, yeah, you just showed me optimal, but is there a near optimal that might be kind of okay? And we're going to show you that in a little bit. Everything I showed you asserted that there was a particular way to define our health outcomes of interest, a way to define myocardial infarction, a way to look for liver injury in a database. And as many of you know, within OMOP, we've also been trying to study how alternative outcome definitions might influence the results. And so we'll talk about that. Mark went through a very nice presentation about OSIM2 and how we could use OSIM2. And many of you have seen in the literature, and we've talked about, there's some people that have an opinion that, maybe a risk identification system will work really well for relative risks greater than 4, but maybe we can't trust it for less than 4. Or maybe it's 2, maybe it's 2.5, maybe it's 3. The problem is with real data, it's awfully hard to answer that question because we don't know what the true effect size actually is. But by using OSIM2, we're able to actually measure the performance at different signal sizes, and we've got some insights to share about what we observe about when it looks like a risk identification system truly will be reliable, and the situations for which we maybe should have a little bit more caution. And then finally, what I'm going to go through is some discussion about heterogeneity that we observe, both in terms of disparate estimates that we observe across our data network, as well as the sensitivity that's observed when you make alternative study design decisions. And I think that that was interesting last year and caused some consternation. And I think we've actually made some progress to think about why that's happening and what we can do about it. All right. So first things first, performance of different methods. I kind of cheated on you, and I just showed you the optimum without giving you a sense of what the other options would be. And so here was that optimum. I'm showing you now a plot. Let me just orient you to it so that you're familiar with it. Actually, that handout I gave you, the blue handout, is basically that grid of the 4 outcomes in the 5 databases, and each one of those had an AUC. Basically, I'm just showing you a graphical display of exactly that table, where the databases are the columns, Medicare, CCAE, Medicaid, etc. The 4 partitions are our outcomes, kidney injury, liver injury, MI, GI bleed. And then the dot is reflecting the AUC that we were able to observe. So that's the optimum. That's the best we could observe thus far, choosing study designs within that particular analysis. So the question is, well, where did all the other methods that Paul talked about, where did they stack up in this picture? And here's your answer. So another eyesore, but just to orient you again, actually I think it's I make you hold your blue sheet and your green sheet. Your green sheet is telling you about all of your different methods. And we didn't color code that quite right, but basically just to help you with the abbreviations again, we implemented a case control design, CC, a cohort method. This is basically our new user cohort design with propensity score adjustment. DP is the disproportionality analysis methods that have been adapted for longitudinal data. Temporal pattern discovery. Longitudinal, the LGPS method, which is actually an algorithm developed by Martijn Schumi and applied in the EUADR effort, and the observational screening, and then the self-controlled case series. And for every one of these databases, what you're observing up here is the best setting of that method that we were able to explore within our experiment. And so just to start with a first orientation here for kidney injury in the Medicare database, you can see that we already told you that the optimum was a self-controlled cohort design contained within the observational screening method. Second place there was temporal pattern discovery with an AUC still greater than 0.8. Third place there was self-controlled case series. Then there's our new user propensity score cohort design, still generating pretty impressive performance, about a 0.75 or so, and on down the list. Now, a couple insights came out of us looking across methods. Well, first things first is, we wanted to see what's winning the day. And in particular, actually the question that was asked to me was, well, you're showing me optimum, but is there anything that's near optimum? And let's start with kidney injury just to see if we said, okay, maybe I don't just care about who wins the race, but I want the top 3 finishers. What we actually observe that's quite interesting is across several of the databases, the winners are the self-controlled cohort design and observational screening, the temporal pattern discovery, which is another self-controlled cohort design, and the self-controlled case series. That wins the day in Medicare, wins the day in CCAE, wins the day in MSLR, wins the day in GE. And the new user cohort design, it slid into second place in the MSLR database. Now, I could go through and do that for every plot, but you can probably read the colors there. But the big insight that we had here, which I thought was actually pretty fascinating, was my confession for you is I had thought about this observational screening approach. I'm looking at Steph. I don't even remember when we first developed this, 6 years ago or something like that, and I didn't think much of anything about this self-controlled design. Even when I developed it, it just seemed like, okay, post-exposure, pre-exposure, why the heck not? But what's interesting is the observational screening implementation was completely independently developed and independently conceived from the Uppsala Monitoring Center in Sweden, where Nicholas Norén and his colleagues developed the temporal pattern discovery approach, which it was only after Nicholas and I sat down over a beverage or 3 and discussed the actual details of the methods and realized that, for the most part, we're really doing the same thing. There's details around the edges, but for the most part, they're quite similar. And it was only after we started working with David and thinking about self-controlled case series that effectively we've got a slightly different selection of data elements that are going into that model, but more or less the conceptual idea. Use an individual in their post-exposure time. Use that same individual and use their pre-exposure time. That's the common thread that holds those 3 methods together. And what we observe pretty consistently across all 5 of these databases and across all 4 of these outcomes is that flavor of a design, that idea, seems to be something that actually performs quite well consistently across the board. Now, you might still not like the self-control philosophy, you might like the new user cohort design, and you can see what the performance is in a variety of contexts. It still can perform well. Remember, if you remember going back to those clinical diagnostics, we got things in clinical practice anywhere between a 0.6 and a 0.8, and you can see that in many of these situations we are getting performance at or above that level kind of across the board. So we're not making any sort of assertions to say you have to do what we're telling you to do, but it actually was very reassuring to us that we were able to observe this type of performance consistently across the 3 independent implementations of a similar kind of idea, and to see how it actually consistently bore out in this experiment. All I've done here is I've just flipped the graph on its head, so now what I'm showing you is a column for every method, and the dots are now colored by the various databases. And again, what I just draw your eye to is the fact that temporal pattern discovery, observational screening, and self-controlled case series, so those self-controlled cohort designs, they tend to look better consistently across the databases for kidney injury, for acute myocardial infarction, for GI bleed, and for liver injury. Collectively, all of the estimates might be a little bit lower, but still those methods seem to perform fairly favorably. Which had we only had one implementation of a method and only applied it to one database, maybe it would be anomalous. But I think we're starting to see something that could potentially be an important finding for us to think about how self-controlled designs have a future in this space of risk identification, maybe even more so than we had previously appreciated. All right, so this was the OMOP experiment. We took OMOP's 399 test cases, applied to OMOP's data sets. We're very fortunate to be able to collaborate with the EUADR Alliance, to work with Miriam and Martijn. And one of the things that we were able to share as part of that collaboration was we were able to look at the performance of OMOP's data sets against EUADR's test cases. So again, just to reiterate, EUADR independently created their own set of positive controls and negative controls beyond just the 4 outcomes I'm talking about. They looked at 10 outcomes of interest. And I think there are actually more results about this on John Lucas posters out there, and I encourage you to take a look. But one of the interesting things that came out of when we were able to implement some of our methods against EUADR's test cases, what we observed was a pretty similar performance. Self-controlled case series, observational screening, self-controlled cohort design, temporal pattern discovery seemed to outperform case control designs and disproportionality analysis. And that was kind of consistent across all 5 of the databases that we studied internally. Now, one of the interesting deviations was the LGPS method. Whoops, sorry. So the LGPS method, Martijn wrote an excellent paper in Pharmacoepidemiology and Drug Safety that I'd suggest that you all read, that talks about this novel design, effectively adapting the disproportionality analysis approach to take advantage of longitudinal data, and then also developing a novel strategy for dealing with protopathic bias. Within the EUADR experiments, this method works extremely well. Within the OMOP experiments, we are not observing it working as well. And we've spent quite a lot of time trying to think about why this is happening. Intuitively, the design seems to make perfect sense. And yet, it's the only difference we really observed when comparing the OMOP results with the OMOP test cases to the OMOP data with the EUADR test cases. And we really spent a lot of time interrogating that, and to the best we can come up with, what our hypothesis is that the LGPS method, while it does a nice job of adjusting for time and trying to deal with protopathic bias, it does not have as many adjustment strategies for confounding. And as we started to look at the different test cases, the OMOP test cases and the EUADR test cases, what we started to observe is, I think, within the OMOP test cases, we had a lot of more difficult scenarios, drug outcome pairs that had a lot of confounding going on. Whereas in the EUADR test cases, we observed that they might have been a little bit cleaner test cases. And so all of that's a long way of saying that I think the LGPS method has some promise, but I think the conflicting results that we're observing suggest that, both the conflicting results we observe for that method, but also this remarkable consistency that self-controlled cohort designs and self-controlled designs in general seem to perform well. That gives us a lot of reassurance that this is an area that we may, as a community, want to explore further. All right, so one down. So next one, evaluating alternative HOI definitions. So again, as I mentioned, there's lots of ways to go find outcomes in these databases, and what we've tried to do within the OMOP experiment is study some of those different variants. For those of you who might be new to it, if you want to actually go look at the particular definitions, they're available on our website. But effectively, the idea was, we're dealing with observational healthcare data. Typically, these outcomes might be defined by some set of ICD-9 codes, but we might want to create narrower definitions by imposing additional criteria, such as restricting based on procedure codes, whether they be diagnostic procedures or treatments. We might also want to further restrict based on seeing elevated laboratory data. And the degree to which these alternative definitions can and should be applied to the data is a question that really hasn't been studied. All too often we come up with a definition, we apply it, we might do source record verification to see if it's good, but we typically don't have the luxury of being able to evaluate alternative choices we could have made. And so what we try to do with the OMOP experiment is try to understand, well, does it actually make sense to always use a narrow definition? Does it make sense to use a broad definition? And as we started to look into this, so we've had some counterintuitive but potentially interesting results. So let me just walk you through a quick example. So acute kidney injury, for example. We had 3 different ways to find acute kidney injury in our observational databases. The first is this light green bar, where basically we had defined acute kidney injury based on ICD-9 codes, anything in the 584 family. Our second definition, which was a proper subset of the first, required that not only does the patient have the diagnosis code, but they also have to have an acute dialysis sometime within the 60 days after they had the diagnosis, and they could not have some sort of a code for chronic dialysis. So we really were trying to make sure that we distinguish between those acute events. A different definition, which is an overlapping definition, albeit independent information, is that in data sources where we have laboratory data, we have an opportunity to look for elevations in serum creatinine and to try to understand whether or not we could in fact identify cases on the basis of this creatinine. I should say that Aaron Katz has been working with us, and he's actually been doing some very exciting research and trying to understand the degree to which these definitions are reliable. And any medical journal editors in the audience that would like to see Aaron's paper, we'd love to hear from you. Not just you, Michael. But we've been able to explore these different definitions and try to understand how well they work. So part of the question we want to ask is, well, those were 3 different definitions. What would the expert community choose? How would the experts choose to study acute kidney injury? And so we were able to, again, rely on our EDDI results to ask the question of, okay, given the choice, you had an option. You could have used definition 1, 2, or 3. Well, what would you choose? And what we observed is, let me again orient you to the picture. The columns here are, again, our outcomes: liver injury, acute myocardial infarction, renal failure, and GI bleed. The rows there are the various different drugs. And again, we posed a simple question. If you're going to study, let's pick a different one. If you're going to study acute renal failure and amphotericin B, which of those definitions would you like to use as your process? And what we can see for renal failure was more or less people seemed to choose definition 2. That was a diagnosis code with an accompanying procedure code. But you can see some people used the broader definition. Some people opted to choose the definition based on laboratory data. And some people said, I'm going to just create my own definition altogether, which those of us who've read the literature see quite a lot. What we observed, though, across all 4 of these outcomes was that the community at large, our experts that are thinking about these problems, there's a lot of legitimate reasons why all of these definitions might be reasonable. And in fact, when posed with the same exact question, reasonable experts might make different choices. And so this is why we think it's really incumbent on us to be able to study which of these definitions actually seems to make most sense and what will yield the best predictive accuracy. Okay, so going back to kidney injury, looking at those 3 definitions, what I first want to show you is what is the background prevalence of acute kidney injury when we apply that definition to the data. And I'm showing you 4 of the databases here. What you can see is that for acute renal failure, the first definition, we've got a pretty wide range, databases ranging from the GE database having a prevalence of less than 0.1%, all the way up to the Medicare database having a prevalence of about 4%. With definition number 2, where we impose the requirement of having procedures, logically that's a proper subset, and therefore the prevalence will be lower. And sure enough, you see that now the prevalence is down below 0.1%. And you can see with definition 3, that was the definition that required laboratory data, that only 2 databases, in fact, had sufficient laboratory data at all to be able to answer that question, and that the prevalence in GE, we actually found more cases using the laboratory definition than we did using the ICD-9-based definition, whereas in the MSLR database, it was actually fairly consistent between diagnosis and liver injury. Okay, so clearly we've got a difference in the prevalence. If we use a broader definition, we're going to find more potential cases. We use a narrower definition, we're going to find fewer cases. The result of that, if we go back to our earlier presentation, we made a decision that we think it makes sense to restrict your experiment to those that you have sufficient sample size. Sample size is a function of the prevalence of the outcome, which means choosing a broader definition is going to allow you to study more test cases. Choosing a narrower definition is going to allow you to choose to look at fewer test cases. And all this plot is showing you is that the trade-off that gets made by imposing a sample size restriction, how many test cases you lose by these varying definitions. And what you can see is the broad definition, definition number 1, just diagnosis codes. For the most part, imposing those restrictions, we're still able to maintain a fairly rich set of test cases. There's still a lot of drugs out there that we can study using that outcome definition. However, with definition 2, by having that narrower subset, just by imposing a procedure code restriction, what we see is several of the databases immediately run out of test cases for which they have enough data, and the others, we really lose out on the opportunity to use that data on the basis of our requirement for restriction. So on the basis of that, so one strike against a narrower definition would be, well, there's fewer things you're going to be able to study. But given that consequence, how well does it actually work? Well, what I'm not showing you here, what I'm showing you here is actually the performance of basically the optimal method applied to here 4 different databases across all of these different methods, and across the 3 different definitions. Let me back up. That was completely muddled. Let's try again. Acute renal failure, definition number 1, our broad definition. Here's how well the methods performed in the Medicare database. Again, this is what you already saw before. The optimal observational screening method could get you an AUC of around 0.9. Now, we think if we had a narrower definition, we might actually be able to get much better performance. And actually what you see is that methods tended to be about the same level of predictive accuracy, or in a couple situations actually a little bit worse. And that pattern actually seemed to hold up across our 4 different databases here. That is, while we would hope, and at least my intuition told me, by having a richer set, a more specific set of outcomes, we'd really like to get better predictive accuracy. In fact, what we consistently observed in this case was that we were about at the same level. That is, our predictive accuracy, whether we used a broad definition or a narrower definition, was about the same. That said, the narrower definition was able to be used for fewer test cases. So where am I going with this? Well, this is somewhat counterintuitive. I think as a community, we need to develop better strategies for defining outcome definitions, and yet we need to be able to evaluate the performance of those outcome definitions to make sure that it's not just that we've done a better job at ascertaining cases, but that we're doing a better job of identifying credible associations. And so our colleagues at Auburn, Rick Hansen and others, have been doing some really exciting work trying to come up with a systematic process for defining outcome definitions, and I'd suggest you check out their posters during the break. What we've observed thus far was our definitions that we were able to use, even though they were a narrower set of cases, it was not actually yielding better predictive accuracy. Just in the interest of time, I'm going to flick through this real quick just to say this same pattern we observed not just for renal failure, but we also observed it for liver injury and for MI. So with liver injury, we studied a wide array of 7 different definitions, going from a broad diagnosis-based definition all the way down to a narrow definition requiring elevations in ALT, AST, and bilirubin. And when we apply those narrower definitions, as you would expect, you have a lower prevalence consistently observed across the databases. Lower prevalence means that you're going to have fewer test cases to be able to observe consistently across the databases. And yet, when we look at predictive accuracy, we were not able to observe patterns where using a narrower definition for liver injury improved our predictive accuracy. Instead, we were basically around the same level of performance, sometimes maybe a shade lower. Now, Stephen Evans pointed us to some interesting work that's being done, and maybe he'll talk about it in the panel. But there's already been some publications that have actually suggested that imposing a narrower definition actually can introduce bias, because you now have a selection process going on for who it is that would have the necessary data elements to in fact meet your definition. And so the notion of source record verification might in fact be something that's not only helping us find better cases, but might actually be introducing bias into the process. I'm not sure that our data necessarily is a proof of that, but I think it's at least suggesting that they may be onto something, and potentially during the panel we can talk about that further. Again, acute myocardial infarction, more of the same. We could have a broad-based definition, or we could have something narrower requiring procedures. Narrower definitions get you fewer cases, maybe more specific cases, but having a narrower definition and a lower prevalence means you're going to be able to study fewer test cases. If we could study fewer test cases and get better predictive accuracy, we'd be okay with it. But again, what we're observing is you get fewer test cases and you're getting about the same predictive accuracy, which at least we've been really struggling with these findings because effectively what they suggest is broad definitions might be the way to go for a risk identification system. That is, it's better for us to have a more sensitive outcome definition than it is to have a more specific outcome definition. And that's certainly counterintuitive to me, and I think it certainly is worthy of further research in this space. But it was consistently observed across our 5 databases and for the 4 outcomes that we studied. So again, just to reiterate here, against these 3, use of the broader definition, that seemed to get us the highest prevalence, the largest number of test cases, and yielded a comparable AUC. And so this might give us some hope, at least, for those of us that are really worried about, geez, I really need the most specific definition. I have to have a database that I can do source record verification in, otherwise I'm completely lost. This might actually give us some hope that the data that are out there, such as commercial sources and organizations that don't have access to source records, maybe in fact that data can be useful because it's better to have the broad definition, or at least doesn't hurt us nearly as much as we thought it might. Okay, performance of different signal sizes. So let's see. So I think Bob O'Neill has a paper, and I know Bob Temple has a paper that talks about when is it, how big does a signal need to be in order for us to believe it in an observational study? And that's an active topic of discussion. We sought out to try to answer that question through simulation. And the reason we needed to do simulation is because we needed to be able to know what the true effect size was to see whether or not we could identify it. And here are basically the results of that. I know I'm like shooting a fire hose at you and hoping that you're drinking a little sip here, but you can just trust me, I guess. What we're going to show you here, and just to orient you to, you should see a little bit of this in the afternoon as well. I'm orient you to the picture. We've got a trellis plot here, again, partitioned out by the outcomes: kidney injury, liver injury, myocardial infarction, and GI bleed. On your x-axis now, what I'm showing you is the signal size that we injected into the simulation. So we knew for the test cases we studied, we started by creating a simulation with no signals. There was nothing in the database, and we could just measure performance in terms of what we'd hope is, since there's no signals, it shouldn't really do that good of a job of predicting performance. And in fact, actually, you could see somehow magically some of the methods actually did beat random guessing. But what's actually most important is what we were able to do is systematically vary the size of the signal that we injected. So we injected a relative risk of 1.25. We injected a relative risk of 1.5, of 2, of 4, and of 10. And so let's work our way backwards. If a risk identification system, if its only goal is to find safety issues that have relative risks greater than 10, I'm here to tell you we can do it. Yes, we can. We're in a situation that basically any method we pick is going to be able to discriminate relative risks of 10 from nothing, okay? Is everybody satisfied with that? Or does anybody want to argue with the fact that we can't find relative risks of 10? No? Okay. So that's promising. So when we look at relative risks of 4, we actually see the same thing. If all we wanted to do was have a system that could find relative risks of 4 or more, we can take it to the bank. For the most part, we can pick a method that will reliably discriminate effects of that size. Now we get into the range that I guess is the juicier area. If we think about a relative risk of 2, what we observed is that there are, in fact, many settings of certain methods that will successfully discriminate relative risks of 2 from no effect. However, what we observed is that, for example, the new user cohort design with propensity score adjustment, the best method we could identify for kidney injury within that family of methods got us an AUC of 0.9. That is to say that there were some relative risks of 2 for which that design failed to discriminate all of the positive controls from all of the negative controls, either because a negative control generated too large of an estimate, or conversely a positive control generated too low of an estimate. But for the most part, the self-controlled designs, if you were to select a self-controlled cohort design, the optimum setting for those could discriminate positives and negatives pretty well. Now we get into the region that I guess gets even juicier. So we'd really like to have a system that could allow us to discriminate between relative risks of 1.5 and no effect. And yet what we observe is, if that's the effect size that was injected into the simulation, what we observe is we can still do pretty darn good. There are methods that are getting us AUCs of 0.9. However, you notice that consistently within kidney injury, actually, just with kidney injury, none of the methods could perfectly discriminate relative risks of 1.5 when trying to study kidney injury. So for kidney injury, we're going to sacrifice reliability when we get down to an effect of that big. In contrast with liver injury, there were some method designs that pretty much could discriminate 1.5. But if we're looking for effect sizes of a liver injury of 1.25, so a 25% increase in the background rate for the exposure, what we observe is the best of the methods get an AUC of 0.9. Now, what I'll tell you, what I take away from this is that what we observe is there are methods that can be highly predictive of identifying effects of all sizes. If as a society we decide that what we really want is to have complete assurance that we're going to find all really massive effects, relative risks of 10 or more, we can tell the public that we can do it now. If we apply these methods, we can do that. However, if we are going to be playing in the area of thinking about effect sizes of 1.25 to 1.5, 1.41, anywhere in that range, we are probably in a situation where if we make the appropriate selection of methods, we probably can generate reliable evidence, but it is not going to be definitive. That is, we are not going to have a perfect prediction. And that's selecting the best method we could find, again, amongst our set, applied to this data in a simulation context, which is probably an oversimplification of the real world. What we observe is effect sizes less than 2. We're not going to have a perfectly predictive model, but we can have a model that does generate credible evidence that could potentially be used as just one more piece of evidence alongside everything else to support our understanding of the safety of medicines. Okay, so I think Bob and the other Bob who've been saying relative risk greater than 2, maybe that's useful. Here's the data to back up their assertions in JAMA from 2004. But I think it's at least assuring to us to be able to have some empiric evidence that actually really gives us confidence that, yes, large effect sizes we'll be able to identify. And also gives us confidence that if we're really looking for gigantic effect sizes, we can kind of pick whatever method we want. All designs could potentially pick something out. However, we really need to be very circumspect about that. What we really need to be thinking about is what is the best method to identify these effects. And what we observe is you do start to see discrimination about what methods work best in which circumstances. And once again, a theme of the day, self-controlled designs really seem to suggest that there's quite promise in allowing us to be able to discriminate these findings. All right, see, we put this agenda slide in here so you could see that we were actually making progress to get you to lunch. So on number 4, we're going to talk about here is data source heterogeneity. And so this is actually some of the findings that we had from the original experiment that we've actually spent a lot of time trying to think through and understanding why it is that when we apply one method consistently to multiple databases, that different databases seem to generate different estimates. And so this is a result from the original OMOP experiment that Mark showed you, but just to orient you to the picture, here we're applying that new user cohort design using high-dimensional propensity score adjustment. And what you're looking at here is a plot where on your x-axis I'm showing you relative risk. On your y-axis, I'm showing you a variety of different drug outcome pairs. And just for simplicity, I've restricted this to the 4 outcomes that we're focusing on today: renal failure, liver injury, myocardial infarction, and GI bleed. And what you get in this plot is a dot for every database estimate that we observed. So you recall from Mark's presentation, we have, in the original experiment, we had 5 central databases and 5 distributed partners, so 10 databases overall, most of which were able to run the suite of methods, many of which were able, for example, to implement this new user cohort design. And for every one of those databases, we generated an effect estimate, the relative risk. What we're plotting here is what that relative risk was for each database. And just to give you a cheat sheet to interpret the colors, red dots are positive and statistically significant. The lower bound of that confidence interval was greater than 1. The p was less than 0.05. Those would have been things that we would have felt like we've got positive evidence for. The blues are statistically significant in the negative direction. That is, the upper bound of the confidence interval was less than 1. The p was still less than 0.05, just on the other side of the two tails. And the yellow dots represent test cases where the estimate was non-significant one way or the other. So the confidence interval contained 1. The p-value is greater than 0.05. And so that's the colors. And then in terms of the shapes, just to give you another cheat sheet here, the circles, those reflect drug outcome pairs for which all of the estimates were at least directionally consistent with one another. And the stars are situations for which we had one database that said it was statistically significant positive, and one database which said it was statistically significant negative. Again, so for example, let's read this off. Benzodiazepines and MI. We applied a new user cohort design using propensity score adjustment, using the exact same algorithm to study benzodiazepines and MI across our network of databases. One of the databases generated an estimate of about 0.7, which was highly statistically significant in the negative direction. And another database generated, using the same exact algorithm, generated an estimate of north of 1.5. Now, I don't know which one's right, but I know they're not both right. And in fact, what we observed in a variety of our experiments was that there were several situations for which multiple databases or 2 databases could yield conflicting results. And of course, this isn't necessarily new to any of us, and we use multiple databases to study the same question, and sometimes we can get conflicting results. But what we've actually been focusing on is trying to quantify just how often should we expect this to happen. If we build data networks that are comprised of 13 data partners, and we're trying to understand, okay, we're going to get 13 estimates back, how often is it the case that we should expect them all to agree, and how often is it going to be the case that we get divergent results? And what we observed when we applied the new user cohort design was that in approximately 24% of the cases that we looked at, we would have at least one database with a statistically significant positive estimate and one database with a statistically significant negative estimate, basically giving us something that we need to be able to explain. The other thing I should note at this point is we looked very carefully for, okay, well, maybe it's just one bad database. Maybe there's a rogue data in there that's always underestimating or always overestimating. And yet, if we take any 2 databases from our data network and just compare, sometimes database 1 is higher and sometimes database 1 is lower than another database, and that held for every permutation of every database, which is basically to suggest there isn't some sort of, at least we did not observe any sort of systematic process that was causing this to happen, but instead I think it raises awareness that we should be paying attention to how databases are different and why we shouldn't necessarily expect to always get replication when we conduct our studies. Now that was new user cohort design, and that's one approach that could be applied. Of course, we applied multiple methods, and here's just another illustration, the same exact plot, but now I've changed it to thinking about the self-controlled case series method. And when we look at that, we actually saw a pretty similar phenomenon. We actually see more stars on this picture, and in fact, in 48% of these test cases, we observed two databases having statistically significant conflicting evidence. And to a large extent, it was because this algorithm tends to underestimate the variability. That is, the standard error that the method produced tends to be a lot overconfident in its estimate. And as a result, you get estimates slightly above 1 and slightly below 1, but both telling you that there's something statistically significant there. And this afternoon, what we're going to talk about is what does it actually mean to be statistically significant in an observational data. And I think we've started to develop some proposed solutions that will help us overcome some of the problems that we're observing here. But I guess just to raise the flag, one of the things that we are paying attention to and sensitive to here is that as we move into this area of having data networks and multiple databases together, we should be in a situation where we need to pay attention to how databases can be different. We should think about why data are different, and we should kind of go in with an expectation that estimates are likely to be different also. And we probably need to, as a community, work together to develop strategies to figure out how we're going to overcome this other than just shrugging our shoulders. All right, everyone's probably excited that the last bullet is bolded now. I'm going to talk about parameter sensitivity. So what I just described was I held a method constant and applied it consistently across different databases. We have another option, of course, which is to hold the database constant and systematically vary choices within a method. And we had a picture like this last year that seemed to cause a little bit of angst amongst some people. And so I'm going to try to explain a little bit better what we did and why we did it and what we're observing. So another eyesore picture. I'm going to try to make it a little bit easier to understand here. We're going to talk about a case control design for a second, a standard case control design that Paul was illustrating. On this plot, I'm going to focus on the CCAE database, so only one database. We're holding the data constant, a privately insured population. Again, on your x-axis, I'm showing you the relative risks. And again, the color, just as a cheat sheet to see, is that the reds are statistically significantly positive, the blues are statistically significantly negative, the yellows are insignificant. And I'm just showing you a couple of the examples. Paul marched you through a series of published papers, and so we just wanted to see, well, what would happen for those same published pairs, for sertraline and GI bleed, for isoniazid and liver injury? What kind of estimates could be observed if we systematically varied all of the choices that could be made within a case control design? So let's show you a particular example here. So for sertraline and GI bleed, actually, let me back up just to orient you to the picture. What I'm going to talk to you about is that every dot on this picture represents one possible way a case control design could be applied to this data. Remember, Paul talked to you about all those parameters, the choice of number of controls, the time at risk window, whether or not you want to nest your case control within the indication. Basically, every dot here is one of those rational choices that someone could make. So here's an example of a rational choice, at least I would think so. It looks pretty consistent with what was published. We could study sertraline and GI bleed using a case control design where we said, let's have 10 controls per case. Let's have a required observation time of 180 days. So we want to make sure that people are in the database so that we can observe covariates. Let's use a time at risk of 30 days from the exposure start. So we're really going to be looking for kind of acute GI bleeds. Let's not consider the index date to be part of time at risk, because maybe that's a little squishy. In terms of selecting controls, why don't we match our controls on age and sex? We won't nest within the indicated population. We'll only look at first occurrence of exposure, so we're only going to be looking for basically the first time that we saw sertraline in the data. And we'll do Mantle-Hansel adjustment for age and gender when we estimate our odds ratio. The show of hands, how many people feel like more or less that seems like a reasonable case control design? Alec raises his hand. That's the hand I was looking for. Good. All right, so Alec says this is okay. So here is what happens if we hold all of those parameters constant, but instead of matching on age and sex, we also say, let's also make sure that our controls are matched on visit. That is, let's make sure that the controls have a visit around the same date as the index date for the cases. There are many studies that publish that do this, and the philosophy behind it anyway would be you want to make sure that your cases and controls are kind of similar in terms of health service utilization around the time of the outcome. I'm not here to say that that's a good or a bad idea, it's a reasonable idea that's been published. Well, when we applied that same exact cohort design and just changed the matching strategy, what we observe is we now get a relative risk of 0.73, statistically significant on the negative direction. So pretty much the same exact design, one parameter choice different, a parameter that honestly I probably wouldn't necessarily have thought too much about as being that big of a difference, but there are at least an example where it can happen. Isoniazid and liver injury, just to show that it's not just a matching problem. Here in isoniazid and liver injury, we get a relative risk of 3. In a study design where we have 10 controls, we've got a time at risk of length of exposure. We're nesting within the indicated population, and we're using Mantle-Hansel adjustment. So kind of typical vanilla stuff. Now for isoniazid, if we're nesting within the indicated population, that means we're basically only focused on people who have tuberculosis. Had we just done a case control design without nesting, we would have actually generated a relative risk of 7.2 with a confidence interval going from 5 to 10. Now what you can see is that these confidence intervals don't overlap. Now, I'm not saying any one of these is right or wrong. They're in fact asking slightly different questions, but I think it's actually incumbent upon us as a community to think about these choices and to both be more transparent about these choices and think about the consequences that they might have in an estimate, not just to postulate what would happen, but we can actually empirically evaluate how that plays out. I think you're probably getting the theme. Basically, we can in general, what we were observing in our experiment was that each of these various study design decisions, we could find examples where holding the study design constant, changing only one parameter, could lead us from having, in this case, a statistically significant negative result to having a null result, just by changing, in this case, whether or not we use Mantle-Hansel adjustment. Now, so last time we presented this, and it caused a little bit of angst, in part because we kind of threw it up there and said, yowzer, don't know what to do about it. What we've tried to do now is try to do a couple things. One is develop strategies to evaluate this, and secondly, just understand, okay, what is the actual magnitude of the problem? In the interest of time, I'm gonna kind of go through this quite quickly, but to say that first thing we wanted to do is understand there's a lot of different choices that can be made in a case control design. How often is this phenomenon happening that tweaking one parameter can actually make your estimate move substantially? And what we observed, this table is actually going to be a little bit difficult to understand, but basically what we observed is across all of our test cases, we asked the question, how much did the estimate move by tweaking one parameter at a time? And what we saw is, for example, nesting within indication, whether or not you make the choice to make this a nested cohort design. In 10% of our test cases, the effect of that was actually pretty small. It was less than 4%. Probably you wouldn't even notice the difference. In half the time, the effect estimate moved by 37%, either positive or negative. The relative risk shifted one direction or the other by 37%. And in 10% of the cases, you could actually basically see over a doubling of the effect, or a halving of the effect, by making the choice of nesting. And the bottom line, I guess the key story to tell you about here is what we observed is that some parameters seem to matter more than others. For example, choice of database, as I just showed you with the database heterogeneity, choice of database matters a lot. We should probably be thinking and being more circumspect about which data we include and how we can use multiple databases to replicate our findings. What we found also is that nesting matters a lot, whether we're matching on visit matters. But what we observed, which is something we didn't expect, was that even some of these smaller decisions, which in general don't impact the estimate too much, we can find scenarios where every single choice moves your estimate by 30% or more. And that is to suggest that all of the decisions that go into an observational analysis, we need to be incredibly transparent about them and to be thinking about how we can more systematically evaluate alternative choices that could be made. Just in the interest of time, I'm going to fly through just to basically say what I just showed you was case control design. Case control design is not unique. We observed the same exact pattern for self-control case series. And in fact, with self-control case series, just flicking one switch on whether or not you're going to use the first occurrence of the outcome or all outcomes would change your interpretation of the effects. And once again, we observe that every single decision within a self-control case series design is important and can matter. We observe the same thing in observational screening. So we just told you about the optimum settings of observational screening. And yet what we observed consistently was we can find scenarios where within these same drug outcome pairs, making one individual choice and flipping that choice can actually be the difference between us declaring a positive statistically significant effect and a negative statistically significant effect. Now, and every decision, once again, matters. So every design, every choice can matter quite a lot. And I think it's important for us to both be more transparent and to figure out how to deal with this. What we're going to actually talk about in the afternoon is some of the ways we can think about trying to get some of this variability and noise into our estimates so that we're not seeing such violent movement in these estimates. So just to conclude, performance of different methods. Self-controlled designs appear to perform consistently well, and it's actually a strong pattern that we observe throughout the results. When we evaluated alternative definitions, what we started to observe is that broader definitions have better coverage and yet comparable performance to the more specific definitions. When we think about performance across different signal sizes, what we observed is that we can have confidence that a risk identification system can discriminate between positive effects that are larger than 2. But when effect sizes are smaller, we probably need to have more caution. And as we think about data across analyses across data networks, we need to recognize the potential and, in fact, the observed behavior that we see substantial variation in estimates across sources that could result in conflicting information, and that the choices that are made within a design, all choices can potentially matter. Some might matter more than others, but all of them should be thought through carefully and selected. And where possible, we should have systematic empirical evidence to support the selection of those choices. So just to recap where we are for the whole morning, and then I'm going to shut up. Where we are now, what we've just shown you is that we can see performance and heterogeneity across these estimates. What we kind of observe is we've seen 5 databases and 4 outcomes, and on the basis of how much variability we're observing, we really don't think we can generalize to other databases outside of our 5 or other outcomes outside of our 4. Instead, what we think is we've established an experimental framework for how we as a community can think about what performance might look like for the 6th database or for the 5th outcome, and hopefully provided a straw man so that as other data networks that are out there that might be used for risk identification, provide them a way to empirically estimate their performance and to provide us a more rigid foundation for which to understand and interpret effect estimates. You all have this handout. Here's our optimal performance that we observed for the morning. And again, the strategies were to partition, tailor, restrict, and optimize. And I'm really excited to be able to say that our evidence seems to suggest that we can achieve predictive accuracy that is potentially a way forward for us to build a risk identification system. Thank you very much.